So with all your permission, everyone, we are starting with the session now. May I have your attention, the esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good afternoon and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the located session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. And it is with great pride that Clarinet serves as a digital partner for this online session hosted by Neonatal Parshala series, and the association is National Neonatology Forum Gujarat. The focus of today's session is lessons from expert, what's new in Surfactant. Now, without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Kunal Ahia sir, the Honorable Secretary of NNF Gujarat, to start the event today with his enlightening words and for the further coordination. So the dice is all yours, sir. Please proceed.
Thank you so much, Rituparna. As we continue with our neonatal Pathshala series, we are lucky to have Dr. Naveen sir with us. As I and Vishal were discussing that what topic we should talk about, Vishal told me, "Don't worry, Naveen sir can take any topic." So it is great to have sir with us. Thank you so much, sir, for joining. Now for the formal introduction, I would request Dr. Vishal Goel to proceed. Thank you.
Thank you, Kunal. So, good evening, everyone. So, today's session is regarding the surfactant. The surfactant actually the greatest intervention in the neonatology to save not only the preterm babies but all kind of thing. So, for that we do have a renowned faculty from India, Dr. Naveen Gupta sir. He did his MD pediatric and DNB neonatology, and followed by he did the fellowship in neonatology in BC Children's Hospital, Vancouver, Canada. Currently, he is working as a senior consultant neonatologist as Madhukar, Rainbow Children Hospital, Delhi. He is also Secretary Association of Neonatology, Delhi State Branch of NNF India. Currently, also he is running a course, NeoScan, from the Neonatal Sonography Clinical Assessment course. And his area of interest is neonatal hemodynamics, neonatal ventilation, care of extreme low birth weight baby. He has a multiple publication and articles, which is more than 15 in number, and also chapters in the books, more than 8. So I welcome you, sir, and thank you so much to take our invitation. And over to you, sir.
Thank you, Dr. Kunal and Dr. Vishal, for such a nice introduction and being kind. And thank you so much for inviting me and making me part of this meeting. So I will stop my video so that my presentation goes seamless. And I will share my screen. So just give me one heads up that my screen is visible when it will be visible. So let me. Yeah, is it visible? The screen is my
Yes,
screen.
sir. Yes, sir. Yes, it's visible, sir.
Okay. Right. Okay. So, I mean, folks or doctors, so my colleagues, thank you very much for inviting me and making the part of this Pathshala program, which is actually very, very nicely going on. And I have heard so many good things about the neonatal Pathshala, which is a nice initiative by NNF Gujarat. So as I was being told that majority of you are doing postgraduate either in pediatrics or neonatology. So maybe my talk at some points will look little bit basics, but that is to make you understand because there may be few of them you are first years, few of you are second years, and few of you must be third year or the consultant. So as Vishal rightly said that when we talk in neonatology, that one of the greatest interventions in neonatology, few greatest intervention in neonatology, which have changed the outcome of these premature babies. One we can say antenatal steroids, and one we can say CPAP, and one we can say surfactant. Surfactant in itself is a magic. So, but how to use, when to use, and so there are few controversies and few things which we should understand before we embark upon giving surfactant. Like when to give, how to give, whether to repeat, and how does it act. So if we conclusively say that how can one person manage the RDS, So few points, few things which are very, very important in managing RDS. One is the antenatal steroids. So not the discussion for today. Second is the delivery room CPAP, and third is the surfactant. Everybody understands that surfactant is good. And when we look at the surfactant in the pre-CPAP era, the surfactant use leads to decreased mortality, decreased air leaks, everything was decreased, but BPD was not decreased. BPD is chronic lung disease. Now the why? So people then came to know from the retrospective data that because these babies were intubated, and even intubation leads to, even a single intubation leads to so much release of the inflammatory mediators that BPD was not less. So then the debate started that we understand that surfactant is very good, but maybe the method to give surfactant is not good. So that's why the newer techniques they come in place. So all these things are very, very good. CPAP is good, surfactant is good, and steroids is good. So today's talk is in surfactant, what's new? There have been a lot of guidelines which have come in the last 3-4 years. One is very nice European guidelines in 2022. Then this RDX next workshop was done, and the RDS neonatal expert task force workshop was done. And in this, it used Delphi method, and the guidelines were framed because there is controversy around so many topics of surfactant. So these I could find, these were the latest one. So we can discuss about them, and at places we can also mention the European guidelines. There are Canadian guidelines, and there is diversity and heterogeneity in these guidelines. We cannot say that one should stick to one guideline only. And there is important NNF CPG guidelines also, which also have been very rigorously made after a rigorous process of the searching of the evidence. So we, in our scenario, can use the CPG guidelines also. They were made in 2021, and we can take these guidelines also. So we cannot be so stringent upon one guideline, but there are few contexts which we can discuss in length. So how these guidelines were made? These guidelines were made with the question survey. 37 questions were surveyed, and then they made three sections. In one section it was establishing diagnosis and indicators, second was about the administration method, and third were other consideration like repeat doses of surfactant, etc. And then these were again consolidated, then the draft statements were made, and then a final statement was made. So this is how two final statements were made and the consensus was achieved. We understand that not every topic can have a clinical trial. So, and sometimes the clinical trials, they are also heterogeneous based on the different population, different methods used, that it is not able to sum up the data in the best possible way. Now let's start it. So how can one diagnose RDS? So diagnosis of RDS, first we should look at the clinical scenario. Scenario means whether we are dealing with premature baby. We understand that more premature the baby is, more is the risk of respiratory distress because the surfactant is less. The surfactant synthesis mainly peaks after 34 weeks of gestation. Antenatal steroids, suppose we are dealing with a 28 weeks baby who has like the mother is in labor, it matters that whether the mother has received steroids or not. So 28 weeks baby without having antenatal steroid vis-a-vis 28 weeks baby with antenatal steroid, they are going to behave differently in cases of RDS. There is documented evidence from many meta-analyses and systematic reviews that antenatal steroids, they decrease the RDS, they decrease air leaks, they decrease IVH, they decrease NEC. Leaking PV, again, infected baby, not infected baby, I will say, but the baby having the risk factors of born to mother with risk factors of infection vis-a-vis no risk factor of infection are going to behave differently in the postnatal period. And if the mother is having gestational diabetes, we understand that the lungs are immature for that gestational age. What does it mean? 35-weeker born to a mother without diabetes and 35-weeker born to a mother with gestational diabetes, the baby who is born to mother with gestational diabetes is likely to have more immature lung and likely to require surfactant in the neonatal period. Then when the baby comes to us with respiratory distress, I'm sure all of you are using some scoring system. There are Downey scoring system, Silverman Anderson, and respiratory distress. There is no consensus that which system is the best. You can use any of the system in your setup. Originally, Downey score was made for late preterm and term babies, and Silverman Anderson score was made for the preterm babies. However, It doesn't matter. What matters is that how we are serially progressing, how we are serially counting the progression or the regression of respiratory distress. Then investigation wise, X-ray and blood gases are good, and ultrasound, point of care sonography, it has started gaining role, and nowadays more and more evidence is going in favor of ultrasound, being its non-invasive nature. So let's take a case: a premature baby, 33 plus 6 weeks, delivered to a primary gravida mother through the cesarean section, birth weight 1900 grams. So whenever you are dealing with such a baby, we should have antenatal question whether there is a steroid cover or not, antenatal steroids, infection, leaking per vaginum or not, and in delivery whether there is resuscitation or not. Babies who suffer asphyxia, more chances of receiving surfactant. Now this was the baby. You can say that the baby is having respiratory distress. Now the thing is that how shall we quantify the respiratory distress? If you can hear this grunting sound, this is how grunting sound appears. And what is grunting? Grunting is when the baby is expiring against a forceful expiration against a partially closed glottis. And when you look at the saturation, the baby is saturating 75% on room air. So now this baby is having grunting, which is audible by naked ear, is having 75% saturation on room air, and is having retractions. Now, how to score this baby? So if I mute this audio for the time being, so how to score this baby? So if we have to do the scoring system, so which scoring system we can use is, so let's say about the Downey score. So in Downey score, there are 5 components. First is the respiratory rate. More is the rate, more is the score given to the component. Less than 60, 60 to 80, more than 80. Then second is cyanosis. So originally it was cyanosis, but we can say that because today is the era when we want to target saturation. And how much saturation we want to target? We want to target saturation is 90 to 94%. And our alarm should be set at 89% and 95% is the upper limit, and 89% is the lower limit. So if we have to, how much oxygen we have to give target saturation, we can give the score. So if we don't need to give oxygen, that means score is 0. And if we have to give, if the baby is in room air, or if I have to less than 40% maintaining the target saturation, that means score is 1. And if I have to need is more than 40%, that means score is 2. Then the grunt, there is none. Audible with stethoscope, audible with naked ear. Retraction, nil, mild, moderate. Air entry with the stethoscope, normal, decreased, bilaterally decreased, or bilaterally absent. Now in our baby, what is the scenario? If we see the respiratory rate, we counted, and you can't count it here, but it was 74 per minute. The baby was in room air, baby was saturation was 75%. So we have to give a little bit of oxygen. So this was 1. Grunting, you could have heard it with the naked ear. Retractions were moderate, and air entry was bilaterally absent. So how much the score is? 2, 2, 2, 6, 7, 8. So total score was 8. So based on the Downey score, we say that less than 4 only oxygen will suffice. 4 to 7 is the time when CPAP is suffice, and more than 7 is something in which the baby may need intubation. So these are not absolute thing, but higher score indicates higher level of respiratory distress, and the clinician should be more serious. The same thing we can do with the Silverman-Anderson score also. What is in Silverman-Anderson score? So again, 0, 1, and 2. There are 3 grades. So first is that how the breathing is. So sometime what happens is when the baby is breathing normally, the thorax in inspiration is going up, and similar time the abdomen is also going up. When the baby is having respiratory distress, then what is happening is there is a lag on inspiration. So in inspiration, when the abdomen is going up, the lower chest is going down. And then there is a seesaw pattern in severe respiratory distress, when in inspiration, the abdomen is going up. However, the chest is going down because the lungs are so stiff, or the alveoli are so collapsed. Then this was for upper chest. Then the lower chest, no retractions, just visible or marked retraction. You can see that they have diagrammatically represent that how the just visible and how are the marked. And upper versus lower is not divided upon the anterior posterior. It is divided from the axillary side, remember that. So this is the upper, so above the mid axillary line is the upper one, and from mid to posterior is the lower one. Xiphoid retraction, none, just visible marked. Dilatation of nares, none, minimal marked. And expiratory grunt, none, stethos only, naked ear. So here the grunt was from naked ear. We can see that the xiphoid retraction is there, which can be, sorry, xiphoid is 1. And we can see that the nares, they are being dilated. They were 2. So 2 and 2 is 4 and 1 5. 5 is still here. Now for the chest side, because we are making this video from anterior posterior, I can't tell you that from the lateral side how the chest is going, but looking at this scenario, even if this is 1 and this is 1, then also the total score is 7. So more than or equal to 7 is impending respiratory failure. So our baby is in problem, and whichever score you use, there is no consensus on the ideal scoring system as per the RDS, the respiratory distress syndrome neonatal expert task force guideline in 2023. So you can use any of these system. However, in our Indian books, majority we read that for premature baby less than 33 weeks, we use Silverman Anderson, and for the term baby, we use the the Downey score. Now, X-ray. X-ray is another important investigation. We will discuss more about the X-ray, but in X-ray, how does this is grade? So you understand that what happens in, suppose this is a normal alveoli. So what is happening in RDS is that the alveoli is collapsed. So this is the RDS alveoli. So when the alveoli is collapsed, so as we understand, then in X-ray, black means air. So if the alveoli is well aerated, then it will be more black. Haziness start appearing when this is less inflated or more collapsed. So first grade of haziness is reticulogranular pattern. First grade of haziness is reticulogranular pattern. So this X-ray, you can see that in this lung, there is a little bit of ground glass appearance or reticulogranular pattern. The second grade is when you see air bronchogram. Look at this left side. You can see that there is an air bronchogram which is there. So what is air bronchogram is? Air bronchogram is when these, normally what happens is, because these alveoli, they are well inflated, alveoli are well inflated, so we cannot see the airways. Airways means the airways means the airways against the airway means the terminal bronchioles. So we cannot see these airways because the alveoli, they are well inflated. When these alveoli, they are collapsed, so they impart a white background. So then we can see the air in those terminal airways. When we see that air pattern in those terminal airways, that is called the air bronchogram. Normally this bronchi or this trachea you will always see, but the peripheral airways when you start seeing, so that pattern is called the air bronchogram pattern. Again, what does air bronchogram denotes? It denotes that the aeration is lesser. So first is the reticulogranular, and then there is the air bronchogram pattern. And then eventually, if there is so much of the alveoli, they are collapsed, it leads to the complete whiteout. You can see that this is whiteout lung, and you cannot distinguish the cardiac silhouette from the lung silhouette. You cannot distinguish that. So this is how from reticulogranular to air bronchogram to the whiteout lung. So this is how grading on RDS. Remember, X-ray takes time. X-ray imparts radiation exposure. So X-ray, we should not wait to give surfactant. We should not wait for the X-ray to happen. Although once we will do an X-ray or get an X-ray done, it can tell us that how severe the RDS is. It can help us to predict whether this baby may need more than one surfactant. The third investigation is the lung ultrasound. So lung ultrasound in the recent past or in the last 10 or 15 years has come up in a big way, and it has been used because it is non-invasive, it is portable, there is no risk of radiation exposure. You can do it in 1 minute you will get the result also. So this has come up in a good way. Linear probe should be used. The baby should be comfortable. And these are the zones. We divide at the line at the level of nipple. The upper zone is called zone 1, 2. On the right side, this becomes R1. This becomes R2. The lateral is the R3. This is the R3. And the posterior is the R4. And normally, for RDS, we do LUS. LUS means lung ultrasound score. So we do score in 1 region, 2 region, and 3. So normally all the studies they have used, majority of the studies have used LUS in the 3 zones. So 3 zones on the right side and 3 zones on the left side. So nowadays people have started using the zone 4 also, and we as a part of NeoScan, or my thought process is that we should always scan the posterior part because of many reasons which I cannot cover right now, but we should scan the posterior part. So this is how these horizontal line, the time doesn't I should everything, but I can say to the new user that this archiform structure is the rib. This is the rib. This is one intercostal space. This first thick line is called the pleural line. And the reflection of this pleural line, they are called the A lines. And if your baby is having only A lines, A means their lung is well aerated. So then the score is 0. That means the score is very less. Now, these vertical lines, if you see in this video, if I stop it, so this vertical line, which is going from here to here, this line is called B lines. As the aeration is lesser and the fluid is more, the B lines, they start appearing. We give score 1. When the B lines are there is emergence of B line, and there are 3 or more B lines in one intercostal space. Now, if there is more loss of aeration, all these B lines, they come in contact with each other, and you cannot segregate one B line from the other, which leads to coalescence of the B line. So there is coalescent B lines. You are not seeing any A line in score 1 or score 2. So you give this as a score 2. So coalescence of the B line. More further lead to aeration, so this is a pleural line, and it leads to subpleural consolidation. So coalescence of B line along with the lung consolidation, so that leads to score 3. So maximum one can have is 18. How 18? Because if there is score 3, so if this is right lung, this is left lung, R1, score 3, R2, 3, L1, L2, or L3, and R3, 3. So one lung is 3, 9. This lung is 3, 3, 3, 9. If we are taking 3 zones in consideration. Here, because initially, because people that RDS disease, there is do the posterior zone. So maximum studies, they took into account 3 zones. Maximum score can be 18. And people used to give surfactant when the score is more than 8. Higher the score, more the respiratory disease. And if I say that, okay, zone 4 should also be taken, then the total score will be 12 for each lung, and it will be 24. So we have to take out of 24. So 8 out of 18 is normally, has in the meta-analysis has shown that if we give surfactant at this juncture, it carries a good sensitivity specificity. So lung ultrasound score has got many clinical application. It predicts the RDS, it guides us giving surfactant therapy, predicts the need of ventilation support, awaiting response to the assessing response to fluid restriction. So far what we have learned is that RDS in a clinical scenario can be assessed by using the clinical method. Any Downey or Silverman Anderson score you can use, and you can use X-ray, and you can use the lung ultrasound depending upon what expertise you have and what is your setup and how is your setup. Now, when to consider surfactant? So mainly some like European guidelines say that when you are guiding surfactant, you take into account only FiO2. FiO2 more than equal to 0.3 is an indication for giving surfactant. So these people, the RDX next guidelines, they have, what do they say is, first take into account the gestational age. 2 subgroups have been made, 23 to 27 weeks and 28 to 36 weeks. First is the clinical status. Downey score should be 4 to 7. That means it is more than 4. Respiratory support status. If you are intubating, you will give. Or if the baby is on NIPPV, MAP more than 6 or CPAP more than equal to 6. Same here. here, but the MAP is more than 7. The cutoff was 6 here and 7 here. Third is FiO2 need. If we are talking about less than 2 hours of age, then cutoff is 30%. If more than 2 hours of life, then cutoff is 40%. Same here. And blood gas, pH less than 7.25, that means there is acidosis, and PCO2 more than 60, that means there is respiratory acidosis. Now, out of these 4 parameters, at least 3 should be present. If 3 parameters are meeting, we should give surfactant. So when to consider surfactant, I found this as a good table because sometimes what happens is FiO2 needs may not alone decide about the lung condition. It also depends upon how much MAP we are giving. Suppose I give you a scenario that I am giving a mean airway pressure of 8 and baby is on FiO2 25%. That is also a severe lung disease. So I give you 2 scenarios. One is baby is on CPAP on a pressure of 5 and FiO2 of 30%. Another is pressure of 8 and FiO2 23%. So this is also sick. Although based on FiO2, we will say that no, there is no problem. But you see that there is a MAP involved and we have given more MAP. So that's why we should take into totality all the conditions. The 4 parameters, the 3 or more should be present to give the surfactant. Role of chest X-ray, the guidelines state that chest X-ray is good for RDS diagnosis and more good to rule out air leak or pneumothorax. See, as the respiratory distress severity increases, more is the baby at risk of pneumothorax. Or in term babies, it is more good to rule out other congenital malformation. So it is suggested, but not mandatory prior to surfactant administration. If we talk about the predictors for determining the need for surfactant, gestational age is a good predictor. Lesser the baby size, more is the risk of RDS, more is the risk of need of surfactant. FiO2 needs we have already discussed, and clinical signs and symptoms with supportive investigations like chest X-ray or blood gases. Out of these, when we talk about biggest predictor for RDS is gestational age, and biggest for non-invasive ventilation failure is FiO2. Now, many a times question comes to our mind that, okay, we have given 1 dose of surfactant, whether to repeat or not. So if the respiratory insufficiency is continuing, if the baby is, you have established a diagnosis of RDS based on X-ray or based on ultrasound, you have given 1 dose of surfactant, and still his FiO2 needs is more, like the baby is now 8 hours old and the FiO2 need is more than 40%. Still, we should consider give 2nd dose of surfactant. So infants with ongoing respiratory insufficiency who receive multiple doses of surfactant, they have better clinical outcomes than those who receive single dose. So don't shy away from giving repeat dose of surfactant. However, we don't have absolute cutoff that how many can be given. Many studies have given even 3 doses of surfactant. So it depends on how severe your baby's lung condition is, your X-ray or your ultrasound associated with your clinical status, and FiO2 and mean airway pressure needs. Now, another very interesting statement was that gestational age should not be considered a sole criteria for administration of surfactant. What does it mean? A 27-weeker baby on CPAP, FiO2 21%, so we will not give surfactant. In babies less than 28 weeks, but however, the result, the many trials were done in which delivery room CPAP with surfactant was considered with the intubation versus surfactant. So what was they find was when there was only CPAP was used and surfactant was not given, like CPAP versus intubation, then the CPAP group, 70% of those babies, they needed surfactant. So lesser the gestational age, there are more chances that the baby will need surfactant, although the lesser gestation age is not the only thing based on which we will say that we should give surfactant. So risk-benefit profile of mode of administration should be considered. We will come to this. Lower gestational age, remember this line. This is a very, very important line. Lower gestational age, LISA is the preferred way, and higher gestational age, Ensure. LISA is the less invasive surfactant administration, and Ensure is you give intubate, you give SURS surfactant, and you extubate the child. We'll come to this. Role of lung ultrasound, we have discussed that early high LUS score correlates well with the need of surfactant administration in preterm neonates with RDS. and lung ultrasound score, it correlated with the oxygenation status and helped predict the bronchopulmonary dysplasia. Now, question about timing of administration. So timing of administration, so one is, people say that can we give prophylactic surfactant? What is prophylactic surfactant? Means you are dealing with the 28 weeks babies. You feel that the baby will need surfactant because baby will have RDS, and you give it before, in the delivery room only, before the onset of RDS, before doing anything, before putting the baby on CPAP. You intubate in the delivery room and you give. The second is early surfactant. Early surfactant means less than 2 hours of age. The table which we used, less than 2 hours of age, you put the baby on CPAP and you see the requirement on CPAP or nasal IMV, or if the baby is intubated, right? And the third is late rescue surfactant, which is more than 2 hours of age and the baby is meeting the criteria. So prophylactic, early and late. So when we talk about, we have to divide this timing is in two eras. One was the era when these small babies, so every small baby was being intubated in the delivery room in the fear of RDS, and then we were giving surfactant. And second was after 2005, when the, or 2000 I will say, when the resurgence in the CPAP use was too much, and people started recognizing that CPAP is a very, very nice thing, and more CPAP was used. So one is the ventilation era and second is the CPAP era. So when we talk about ventilation era, then prophylactic treatment versus selective treatment, prophylactic wins the war. Prophylactic wins the war. You see neonatal mortality of prophylactic surfactant 0.69. 0.69 RR means there is 31% reduction. So it means that neonatal mortality was 31% less in prophylactic group versus selective treatment in the timing when the babies were intubated. And 95% confidence interval is 56.56 to 85. That means that if we repeat this study 100 times, then out of 195 times, there will be reduction, which will be from 44% to 15%. As high as 44% to as low as 50%. So if this is, normally you guys must be knowing the stats, but if I say RR is 0.69 and 95% CI is 0.6 to 0.85, in a second statement I say RR is 0.69 and the 95% confidence interval is 0.56 to 1.4. This is significant, means the reduction is significant, and this is not significant. RR is same. This is not significant because this is crossing 1. So 1 is the line of no significance. If it is crossing 1, if the 95% confidence interval is 0.56 means 44% reduction and 1.4 means 40% more, that means that it can go either way, then it is not significant. So it should be on one side of the 1, then only it is significant. So in the era of invasive ventilation, the prophylactic treatment, the neonatal mortality was less and the air leak was less. And when we talk about early selective, that is less than 2 hour early rescue versus later rescue, then again early selective was good, mortality was less, and combined outcome of death and BPD was less and air leak was less. So invasive ventilation era, prophylactic was good. But what happens is when we talk about rescue therapy, rescue and prophylactic versus rescue, there are two eras. One is when MV is given in the rescue group and one is when CPAP is given in the rescue group. When CPAP is given in the rescue group, there is no difference, meaning that the babies who are intubated, maybe prophylactic is good. Babies where CPAP is being used, then there is no difference. And timing of surfactant in the era of CPAP. Now, the second era of CPAP, we can see that the outcomes are same. Mortality or BPD, same. You see 0.76 to 1.02. Wherever it is crossing 1, there is not significant. So this is not significant. BPD at 36 weeks, this is significant, but it is touching 1. Air leaks were lesser, definitely. Severe IVH was same, mortality was same. So late surfactant administration after 48 hours, is there any role? So after 48 hours, we don't find any role, but we need to figure out the population. We need to figure out the population which needs it. So suppose you have a classic case of RDS and the baby is not improving at all, you may consider after 48 hours. However, after 48 hours, look into other factors. Look into the PDA which is playing a role. Look into giving appropriate sleep. So to summarize, in CPAP era, the prophylactic has got no role. Prophylactic has got no role in the CPAP era. Early rescue is best. So in the CPAP era, what you do is in the delivery room, you put the baby on CPAP and then you assess the, can people mute themselves, please? And then you assess the FiO2 needs and the mean airway pressure needs and the clinical scoring system. And then based on that, you do the early rescue. No benefit of prophylactic in infants with RDS managed on nasal CPAP from the birth. So delivery room CPAP is the key, and make your center equipped where you can give the delivery room CPAP. And optimal timing of surfactant administered by Ensure and Lisa to babies with RDS unknown. However, early Ensure is always good. Routine use of late surfactant therapy in preterm neonates with prolonged respiratory insufficiency is discouraged. Now, another interesting thing is, so we are approximately 40 minutes have elapsed. I will take 5-7 minutes more, try to wrap up the thing. So how to give the surfactant? We have understood from the trials that surfactant is very good. So standard way of giving surfactant is you intubate the baby and then you pour surfactant into the, you put the feeding tube into the endotracheal tube and you give the surfactant. However, as we have seen that CPAP versus intubation, CPAP has won the war because CPAP is non-invasive and intubation leads to more BPD. So then the question arises that if CPAP is good, surfactant is good, why not combine both the things? Combining both the thing is surfactant should be given by the non-invasive method. And what is non-invasive method is, yeah, first kind was Ensure. What is Ensure is IN stands for intubate. You identify the baby. Your baby is on CPAP, but he needs surfactant. So you will intubate the baby. SUR means you will give surfactant and then you extubate immediately. So you intubate, give surfactant and extubate. So Ensure came into picture. However, Ensure was also not so successful in reducing the BPD because in these tiny babies, as we intubate, the lot of inflammatory mediators are released. So then the next thing was Lisa. Lisa. The other name of Lisa is MIST also, minimum invasive surfactant therapy or less invasive surfactant administration. So in Lisa or MIST, there are, you can use the feeding tube or there are special catheters like Surfcath, etc. Your baby is on CPAP, baby is being continued on CPAP, and by seeing the, like through the laryngoscope, you identify vocal cord, and through the vocal cord, you put the Surfcath, and then Surfcath or the like or any other catheter which is meant for this, and then you give surfactant. So your baby is being received the continuous in during the process, baby is receiving the CPAP, baby is receiving the positive and expiratory pressure, so that the alveoli they are not they are not collapsed. Whenever we intubate and we give PPV through specifically through bag and mask, then in that duration the alveoli are collapsed and we take away the benefit of giving the CPAP. So the benefit of CPAP is continued and we give surfactant through the special catheters which are meant for it. Like in India, there is a catheter which comes as a name of Surfcath made by the Wagon people. Or if you don't have this, you can use the feeding tube. Feeding tube is little less stiffer, so you have to be make more sure that it is going in the right way. Now the another method which has come up recently is, let's go even more less invasive. So more less invasive means that you don't go beyond the vocal cords. So you are above the vocal cords. SALSA is the giving surfactant administration. S is surfactant, A is administration In the end, L is the larynx, either the laryngeal or the supraglottic airway. Surfactant administration in the laryngeal or the supraglottic airway. Like we use the LMA, we use the LMA or I-gel that is being put, and the surfactant is being administered through that. So this is called the salsa, where we are administering surfactant in the laryngeal area only. We are not crossing the vocal cords, so we are giving more non-invasive. And then another is too much non-invasive, where if we can give surfactant by nebulization, the baby is being continued on CPAP, and through the nebulization we are giving surfactant. And another studies have been where surfactant has been a vector of giving steroids. So this is how these methods and techniques have gone, and we will look at the evidence of how it goes. So there have been many RCTs and meta-analysis. This is one of the systematic reviews, the Cochrane database 2021 of the thin catheter, that is the LISA versus the standard ET tube. And you can see, look at the outcome, death or BPD. In the LISA group, 0.59, 41% reduction. Need for intubation in the first 72 hours, 37% reduction. Air leak required during drainage, 42% reduction. Severe IVH, 37% reduction. Death during first hospitalization, 37% reduction. Sorry, air leak requiring drainage, there is no reduction because this is 1.02. So this is not reduction. BPD among survivors, there is 43% reduction. So LISA has won the war if when we compare it with the standard ET tube. And look at these are the few meta-analysis. This is one meta-analysis, second, third, and fourth, and outcome of BPD or death. Almost all the meta-analysis, there is a consistent reduction, and the LISA is winning the war as compared to the standard ET tube. And when we look at these areas, so you see that the green means the LISA was superior, and to ensure, and yellow means there was no evidence of a difference. So in these outcomes, this is LISA superior, and yellow means no difference. So LISA versus Ensure. So LISA, you can see that there are many green dots and green boxes, and red means that Ensure was better. There is no red box. So when we compare LISA versus Ensure, then also LISA is better. And to summarize, for prevention of BPD or death, LISA is the best strategy. And if you don't have the expertise to give LISA, then nasal IMV combining with Ensure is the second best. This is the ranking scenario in which the SUCRA is being, this is network plot meta-analysis in which SUCRA, that is surface under the cumulative ranking curve. So these are the ranking curve. This blue is for LISA. Sorry, this blue is for LMA. And the LISA is LISA is this dot. This is LISA. So these are the ranking which were given. The more ranking means that the better is this thing. So what I mean to say is that for the babies who are, and this has been mentioned in the RDS next guideline, for babies who are lesser gestational age, mainly these LISA studies, they have enrolled babies less than 28 weeks. You can say 29 weeks or 30 weeks. LISA is very good. But if you have to give surfactant in a 34, 36 weeker baby, where as such also the BPD is very less, LISA may not be the best way. Why? Because the baby will be fighting and you are intubating, the surfactant may reflux. So the better will be intubate the baby and give it through the intubate, give surfactant, and then take the tube out and continue CPAP. So for lesser gestational age babies, LISA is the best. For more gestational age babies, Ensure is the best technique. Caution while using the LISA is, this is caution while using LISA. Trained personnel you need, because surfactant may go into esophagus also. NG or dedicated device like SurfCath you need. Use of pre-medication. So pre-medication sometimes may induce the chest rigidity, like if you use fentanyl, etc. You want to make the baby calm, but these medicines may have the counter effects, so we do not know. However, low dose fentanyl or atropine can be considered, because atropine will take away the vagal shock which you give. And non-pharmacological or sucrose method should be implied in the first issue. Whenever you do Ensure, when we should extubate, no studies they mention the timing of the extubation, but they should be extubated as soon as possible. We are short of time. This is SALSA, which is the surfactant administration through the laryngeal or the supraglottic airways. And when we look for the evidence of SALSA, there is 5 or 6 studies with 510 newborns. We can see that at 36 weeks PMA, little or no effect on the composite outcome of death or BPD, but may reduce the need for mechanical ventilation. More data for SALSA needs to be done, and more studies are giving by for the SALSA. Aerosolized surfactant, normally it has been tried in the bigger babies, and more data needs to be come for this. What are the advantages? The instrumentation is avoided, PPV is avoided, sedation is unnecessary, technical is signal. Disadvantage is it, administration times are longer, it will need larger dose. And you can give it through all this jet nebulizer, ultrasonic nebulizer, vibrating mesh nebulizer. And when we talk about the evidence, so we see that it is a promising thing. However, it has been, you look at the gestational age, 31, 33, 31, 30, 30, 28. So we need to see it in the lesser gestational age before we jump to some conclusion. So more data is required for the evaluating the use of promising technique. There is no improvement in respiratory status. The coming et al. First to show benefit with a reduction in intubation and surfactant via endotracheal. And currently there is no US FDA approved devices available, but research is ongoing. And surfactant as a vehicle for steroids has also been used, but it needs the further studies. Non-RDS indication, I will summarize. Whenever you have a baby with hypoxemic respiratory failure, HRF, it may be mostly secondary to meconium or the congenital pneumonia, and your OI is more than 15, you can consider giving surfactant. In meconium aspiration, we give surfactant and we give it through the bolus route. Because the time doesn't permit, I will skip this evidence. However, the crux is this. So whenever you have hypoxemic respiratory failure, secondary to meconium aspiration or pneumonia, you have ruled out the pneumothorax, you have ruled out congenital malformation, and your baby is needing a OI of more than 15, you can use the surfactant in with the bolus method only. Lavage method is not recommended. So in nutshell, clinical threshold to give surfactant is unclear. However, you can follow any guideline, RDS next, FiO2 30 to 40, less than 2 hours, cutoff is 30, more than 2 hours, cutoff is 40, and CPAP again, less than 2 hours, cutoff is 6, more than 2 hours, cutoff is 7. Other parameters, clinical scenario is very important. USG lung seems to be promising, needs more research. No role of prophylactic surfactant in era of CPAP. Early Ensure or LISA may offer benefit. LISA may be preferred over Ensure. However, caution regarding the implementation should be there. I will say LISA will be better in the lesser gestational age baby. Ensure will be better in more gestational age baby. SALSA and aerosolized need more research. Surfactant with steroid not there yet. Hypoxemic respiratory failure due to lung parenchymal disease, whether it's MAS or PPHN or pneumonia, give surfactant if the OI is more than 15. Thank you very much. I was a little fast because the time was getting out of the way. Over to the organizers, and I will be very
Yeah.
happy to questions. Yeah.
Thank you so much, sir. It was a really nice session. Like you cover almost basic to advanced thing, to starting from the diagnosis, which include the clinical things and assessment of the all the methods, including X-ray and new things, lung ultrasound. And I think right now the lung ultrasound is also people are used to do. I used to say the people that lung ultrasound is the easiest ultrasound in the world right now, as compared to the echo or ultrasound of head. So people are using over there. It is very promising. And also you really nicely cover the older things and newer thing from starting from the intubation and the surfactant followed by insure and everything. So so any question from the delegates, you can unmute directly and you can ask directly to the sir.
Yeah, actually, I agree with you that lung ultrasound is one of the easiest thing. Like, I mean, you will always get the picture. And so many years we were in this disbelief that the lung cannot be scanned because it is the
Sir.
enemy of ultrasound. I think so. Lung ultrasound is definitely the easiest thing out of all the echo, etc. It needs lesser expertise.
Yeah, I would like to say that because of the lung ultrasound, my fellows and everyone is used to pick up the probe because they are worried that how can I, interpret the things. So that's also the good thing about the lung ultrasound.
Yeah.
Mahesh, Ritu, can you mute, unmute, sorry, mute the other people?
Yes, sir. Yes, sir.
Okay. Yeah.
Okay, so I think there are no questions and there is
No
nothing in the
question.
chat box. Right.
Yeah. Thank you so much, sir. Really appreciate, and I think in future also we would like to have on the board, sir. And it
Thank
will
you.
be really helpful for not only the PGs. We try to cover more and more PGs over here, and also the fellows and DM student. We have Karam sir over here, DM candidate over there. And generally, our most of time we put in the YouTube. Our YouTube views are lots of like in thousands, so it will be beneficial for all of. Thank you so much. Really appreciate, sir.
Thank you. Thank you
Anything
so
from
much, Dr. Vishal and Dr. Kunal.
Kunal?
Yeah, thank you so
Kunal,
much,
line?
Dr. Naveen, for such an excellent presentation. It was an evidence-based and with all the latest evidences. Thank you so much, sir. Thank you, Vishal, for excellently moderating the session. Thank you, Ritu, for and ClearNet for the seamless experience. I thank you all. Now,
Thank you.
over to you, Ritu.
Thank you, sir. Thank you.
Thank you so much, sir, for all your valuable inputs. Thank you, everyone, for being with us. So, with all your permission now, as there are no further questions, we are signing off for today. Hoping to meet you again. Goodbye, everyone, and take care.
Bye.
Goodbye. Bye.
Goodbye. Thank you.
Thank you.
Bye.